Good evening, everyone, and welcome to this, our second yearly WAMAS education evening. It's good to have such a good turnout. For those who don't know me, my name's Mark Hanikeri. I'm the director of WAMAS and have been for the last 4 years. I'm a plastic surgeon based mainly here at St John of God's in Subiaco, and quite a large part of my practice is management of skin malignancies, and in particular melanoma. You've all seen the running sheet, so I won't dwell on it, but suffice to say that we've got a fairly broad range of people speaking to you this evening, all of whom are part of the WAMAS clinical committee. After me, Chris Quirk will be giving you a rundown on making the diagnosis. Mark Lee, plastic surgeon, will be talking about the role of sentinel node biopsy in management of melanoma. Ben Wood, one of our pathologists, will be talking about what is important in the pathology report. Tom Van Hagen, medical oncologist, will be talking about what trials are currently running, and then Dr. Saunders will be, Christobel Saunders will be going through the evidence for multidisciplinary management, the benefits of the multidisciplinary approach in tumours such as melanoma. Finally, we've got a patient advocate, Clint Heal, who heads up Melanoma WA. Whoever doesn't know Clinton, he's a very dynamic young man who is himself a patient who's had melanoma from a very young age and had multiple metastases treated with various operations. Is Clint here yet? Oh, just forget all of that. Ross Taylor, who is also a patient advocate, will be presenting in place of Clinton. I hadn't been informed Clinton's not coming, but I'm presuming that they've had discussions about what they're going to talk about with respect to what WAMAS represents to the community. Before we get underway, I'll just let you know a rundown of what WAMAS does. For those, has anyone here used WAMAS before? It's just show of hands. I just want to know sort of whether I'm preaching to the converted. So about 50%. For those who haven't used WAMAS before, hopefully we'll give you enough evidence this evening that there is benefit in it for your patients, and certainly for yourselves if you need just a resource. We provide a comprehensive facility to provide advice regarding the management of complex melanomas and particularly advanced and metastatic malignant melanoma. For those patients who don't qualify to come to see us in the clinical meetings, and I'll get across the indications for referral shortly, we still provide advice. So if you just get a patient that you don't quite know what to do, even if it's a thin melanoma, perhaps in a cosmetically sensitive area, or you're worried it might need a graft, or you just want to know whether you need to take more away, they don't actually have to come to see us in the WAMAS clinical meetings, but if you let Julie Tarachi know, who's the nurse coordinator of WAMAS, and you'll get those details later, then she usually runs all those cases by me. We can have their pathology reviewed by one of our pathologists, and I'll usually give the GP who refers the patient a call within a week or so with advice on what to do. We also provide advice with regards to appropriate management in terms of adjuvant treatments, and whether further investigations are required for the melanoma, which in most cases the answer is no. And we can, if asked, give information to either the patients or to the doctor on the prognosis for the given lesion. Doctors need to refer patients. Patients can't self-refer, families can't refer, and so if a patient calls us directly, we will usually direct them to their GP to send them in with a referral. It's free, public or private. The WA Melanoma Advisory Service itself is not a treatment unit, so we don't get involved in the actual surgery for melanoma patients unless we are asked to, in which case one of the surgeons or dermatologists will, as part of the clinical committee, will take the management over of that patient. But we will usually send the patients back to the referring doctor with advice on how to manage that patient. If they're public patients, then all of us, or many of the doctors in the team, have public hospital commitments, and we can organise for your public patients to be treated in an expeditious fashion through either Sir Charles Gardner or Royal Perth Hospital. We only see patients with a melanoma thicker than 1 millimetre Breslow thickness. And if there are patients with melanoma less than 1 millimetre who you believe to be important to see a multidisciplinary team, then, as I said, you can let Julie know about them and she'll discuss them with me, and if I think it's appropriate, I'll bring them in to be seen. And obviously if there's any patients who have regional or distant disease. This is an example of our referral letter. It's fairly self-explanatory. It's got all the things that you need for a referral in it. And it's very simple. Tick boxes and simple one-line answers are usually enough. If you'd prefer, because of your computing system, to dictate something or to do something as a pro forma, then we take those as well. But to make it easy, we've got these, and we're soon to have a website. We're in the process of developing a website, and hopefully those forms will be downloadable when that's the case. So what happens when you've got a melanoma patient? Either a GP or specialist can refer to us. You contact the nurse coordinator at WAMAS, and if the appropriate is referral, if the referral is appropriate, then they will be seen usually within 2 weeks. Otherwise a maximum of 4 weeks for less urgent lesions, particularly if the treatment has already been completed and you just want advice, and they'll usually wait for 4 weeks. But otherwise all patients are seen usually within 2 weeks. Patient attends WAMAS and is seen by a panel consisting of 4 people from various disciplines, usually a surgeon, a dermatologist, a pathologist and an oncologist. At that time, at that meeting, which is usually on a Monday afternoon after 5 o'clock, the patient will be given information with respect to their melanoma, and what the panel advises is the optimum treatment. And then at the next meeting, which is usually attended by anywhere between 10 and 20 of the clinicians, that patient is discussed, the treatment plan is discussed and confirmed to be appropriate, and if there's any dissension and people think that the treatment is not appropriate, then adjustments are made accordingly. And after that meeting, usually the GP or referring specialist will get a letter advising them of what the panel has decided to do. So it's very good in terms of the holistic care of the patient, making sure all the boxes are ticked, and that you've got a multidisciplinary approach for what can be a complex and challenging lesion. At this stage, certainly in Perth, WAMAS is the only multidisciplinary unit that deals specifically with melanoma. So that said, the other thing I just sort of mentioned is that in order to promote, as I mentioned, there's only 4 people in each of the panels that sees the patients. In order to ensure that we are all speaking out of the same page, there are guidelines that we've prepared to make sure that it doesn't matter which panel your particular patient sees, they'll get fairly consistent advice. So I have prepared a sheet of information for all the clinicians who attend with guidelines, and once again these guidelines may well be available on our website when it goes public for you to see for further information. I think this is a screenshot from our upcoming website, so we'll let you know when that's live, and when it is live you'll be able to get information on what we do and how we do it, and download appropriate forms. And there'll also be the opportunity to see educational things such as this sort of evening in the future will be recorded, as it is being tonight, and publicised and published on the website. That's the kind of information that you'll be able to get. So with that said, I'm not going to say anything more this evening. I'll leave it up to our experts from the WAMAS panel. And at the end of the evening, you'll have the opportunity to ask questions of everybody. So I'll ask that you save your questions until then. And if you have any questions, there will be a microphone going around. As tonight is being taped, I will get you to speak into the microphone to record your question, and then the appropriate person will give you your answer. So I'd like to introduce Chris Quirk, dermatologist, for the first presentation. Laser pointer there.
Thanks. Thank you, Mark, and thank you for WAMAS for asking me to speak tonight. I'll apologise in advance for my very simplistic approach to the detection of melanoma, because a lot of the new techniques, I think, are perhaps illusory in their benefits to patients. Now, we know that thickness determines prognosis. The thicker the lesion, the closer it is to blood vessels and lymphatics. So it makes sense that if the cells are just in the epidermis and the lesion's in situ, the cells are growing sideways, they're nowhere near blood vessels or lymphatics, so really they cannot metastasise. But once the lesion's thicker, of course, it can. So if we look at some of the methods for detection, there are optical tools, photographic analysis, imaging tools, genetic analysis, and the old dermoscopy. When light hits the skin, it can be absorbed, can be reflected, it can be scattered, and this leads to various techniques for looking at skin lesions. We published this paper some years ago with David Sampson's group at UWA, and we had a simple little tool which we shone onto nevi and melanoma, and we would measure the diffuse reflectance from the skin lesion, and the light would come out of the centre of the probe and be collected by the lesions around the edge, by the detectors around the edge of the probe, and you'd expect there to be difference in these sort of lesions. Look at the pathology, look at the clinical pictures there. You'd expect reflectance to be different in these lesions. What's happened? We missed a slide here, I think. Anyway, as it turned out, there was a fair amount of difference between melanoma and nevi. Slide's gone missing, Julie. What's happened? Never mind. Now, these more advanced machines work along those lines to an extent, and also photographically. Microderm is a German machine, Solar Scan's an Australian machine. But they're put up as the best thing since sliced bread for detecting melanoma. But I'm not convinced. In fact, I'm not convinced at all. These lesions, if you want to find melanoma, you look at patients who are high risk. Now, when you've got a patient with hundreds of nevi, what on earth do you do with one of these machines? Okay, well, the fella down here on the right, he's showing this girl or this young woman that she's got a melanoma that he's found on the scanner. I mean, you could see that lesion's a melanoma from about 20 metres away. I just think they're marketing tools. They work. They are fantastic machines, but really that lesion does not need a fantastic machine to show you that it's a melanoma. There'll be an algorithm where there'll be melanoma on the machine's memory, and your lesion that you're scanning will be compared to that to all those melanomas on the machine's memory. This machine is absolutely phenomenal. It can drag off the pigment off a lesion. It can show you the vasculature of a lesion. But there was a big study done by the manufacturers a couple of years ago, and in Britain and Australia. And there were so many false positives and false negatives with this machine. I was asked to look at the paper. They wanted to publish the MJA, and I said, you must publish this paper because it shows you the limitations of the machine. MJA didn't publish the article, but this woman came in a few weeks later. And I said, what on earth is that? And she said, oh, it's okay. I work for such and such a council, and we have these people come around with a machine every year and give us the once over, and they told me this was fine. Well, again, from 20 or 30 metres, you could probably say that was a melanoma. It's asymmetrical, it's variable colour, and it's large. So, sure enough, that was a melanoma which I excised, but luckily for her, she came in for something else. Now, with a patient like this who's had sort of 4 melanomas, what does one do with one of these machines? Now, I think really you need to have a simplistic approach to this sort of patient. Dysplastic nevi are markers rather than precursors. A lot of people excise dysplastic nevi because they fulfil some of the criteria, the asymmetry, the variable colour. But mostly in a patient with a lot of these, I will be looking at small lesions to see if they qualify to be excised. And you don't often see the big dysplastic nevi being precursors. Patient like this with 60 nevi, where do you start? Well, you've got to have your rules in place. You've got to scan them very quickly. This sort of patient, he's had a few melanomas. This fellow's had a big melanoma over here somewhere. He was in the other day, but he has a lot of irregular nevi. This machine's just been released in the US amidst some fanfare, and a poor dermatologist whose name was Doris Day was on TV the other day, and she was asked about this machine. She said it's fantastic because patients don't have to have scars from skin biopsies anymore. Poor Doris, I think, has missed the point. There's a big argument in the States because really there's a lot of people saying this machine is not as good as they're making out. Ash Margoob he works at Sloan Kettering. He's an expert in this area, and he really doesn't believe they have a place in the GP surgery. I mean, you can buy me a Stradivarius, but I still can't play the violin, and that's the sort of approach. Looking at the confocal laser scanning microscopy device, which is interesting, there have been books written about on the sort of findings you get with nevi and melanoma. But again, a lot of people are not happy to say, look, I trust that is a nevus and not a melanoma, and I'm happy to leave it on. But that's an interesting machine that's still an experimental machine. But I'll bring you back to this point. If you miss it this year and find it next year, the patient's still fine. And what all these machines are doing are trying to get things earlier and earlier and earlier. And a lot of the lesions that I take off are thin. They're mostly in this range. And our practice takes off... GPs take about half the melanomas in Perth. Our practice sees about 200 a year, of which half are referred and half we find by accident. This paper came out a couple of years ago in the BJD and looked at the genomic detection of melanoma, and they strip off with some tape some material from a suspect lesion, and they analyse it and find that the melanoma genes are very obvious over here, and nevus genes are absent. And so that really is an excellent bit of gear, but I'm not sure that it's going to be useful in every surgery. Now, this lesion really has to come off because it's asymmetric and it's, it's variable colours. But really, I don't want to take it off because I know it's a dysplastic nevus. So I guess if I did the tape stripping on that and got the confirmation of the patient, then they would be happy to leave it. But I would be negligent really not taking that off, I think, because it qualifies as melanoma. So really we get back to dermoscopy, which a lot of you are excellent at. And last weekend, the same fellow, Ash Margoob, was running this course in New York, and so they still regard it as very important, even though all these fancy bits of gear are floating around. So it doesn't matter what you use, but you get a magnified view of a skin lesion. This site is very good to go and train yourself if you want to learn dermoscopy from scratch. Willi Stoltz, a fellow from Regensburg in Germany, came up with this paper a long time ago, 1994. But it's worth working through because this gives you a score for a lesion, and you can be strict with yourself and say, yes, it needs to come off, or no, it doesn't need to come off. But really, if you look at asymmetry and the blue-grey veil, I think they are so... he doesn't weight these at all. He comes up with an overall score, but I weight them myself. And if lesions have got a blue-grey veil, that's a sine qua non as far as I'm concerned. Now, John Emery, who's a local, and Scott Menzies from Sydney, and a few other people came up with this paper in the BJD, saying that if you use dermoscopy well, you'll be cutting off less lesions and you'll be referring less. So that's a very important paper. Archives of Dermatology said that if you give the patient a once-over, it'll take 70 seconds, but if you look at them with a dermatoscope, it's going to take you 142 seconds. And even if you've got a lot of lesions, it doesn't take you much less time because the dermoscopist knows which lesions to look at. So he'll probably only look at the same number of lesions in a patient with many nevi or a lot. But, 142 seconds, honestly, I ask you, how much of a impost is that going to be on your daily practice? But, with a patient like this, I will look at maybe 4 or 5 lesions. I'll look at small notch lesions like this sort of thing, but I won't even glance at these large dysplastic nevi. A lot of these patients with melanomas on their back, they've never had their backs looked at. So if patients sun damage, get their shirt off. So, major signs. The ugly duckling, the lesion that looks like no other lesion. Asymmetry, colour variation in the blue-grey veil. This fellow came in, I said, "There's melanoma on your back." He said, "It's all right, I've had it biopsied," and they said it's fine. The clinic biopsied in the middle of the lesion where there was regression, there was no signs of melanoma. Of course that was a melanoma. After I got him out of the headlock, I cut it off, and sure enough it was a melanoma. So ugly duckling, it jumps out at you off this fellow's back. Lady with a pinky brown lesion on the back, that could be a BCC, but it jumps out at you. Another lady with a lesion on her arm, asymmetrical colour variation. So these are other signs. Very obvious lesions. These are the sort of things I see. Small, 4 or 5 millimetre lesions looking like not much, but they fulfil the criteria. They're asymmetrical. They're more than 2 colours. Sun-damaged skin provides a bit of a challenge, but this still qualifies. There's a bit of pink in there, which I'm a great believer in pink. It's a bad sign in a pigmented lesion. Again, a pinky brown lesion with a few colours and not very big. Typical asymmetrical multicoloured lesion, again small, slightly bigger lesion. Blue-grey veil, you won't see it often clinically as you do almost here, but on the dermatoscope you will see it. And you do see it occasionally in dysplastic nevi, but when you see it, it's mostly a melanoma. So you can buy these books, you can sweat over them and look at the small print and the pseudopods and everything else, but unfortunately I've got a very simplistic approach which I reckon works. And so I want you to buy my book when it comes out. It's only 7 pages long, and all melanomas fit onto pages 1 to 7. So you've got to examine high-risk patients. Patients with lots of nevi, family history. Now, unfortunately, the community believes that going in the sun and getting a tan will give you melanoma. That's all very well, but the high-risk patients account for quite a lot of the people we see in the melanoma unit. Ugly duckling. Asymmetry. This lady said, "Oh, my doctor and I are watching this lesion. We think it might be changing." It was thin, so it was fine. Again, more than 2 colours. The blue grey-white veil, it's a trigger for you to remember that. But again, it's a bad sign, and they have it. Pink and brown. Now, this fellow, I took his sutures out today. That was 0.58 millimetres thick. It had been growing only for a few months. He was a young uni student, so his prognosis is excellent. This woman with a couple of little kids had been told by a couple of people that it was okay, and that lesion was fatal. But it just, what is it? It's an odd-looking thing. You can't say it's nothing. It's got to be something. And unfortunately for her, it was a melanoma. It was about 1.5 millimetre thickness, I think. Patients report change. I mean, okay, you'll end up taking off, traumatised nevi and seb warts and a few other things, but you should never, ever ignore the patients. I mean, if they say it's changed, it's changed. So looking at how bad outcomes occur, patient denial, patient ignorance, we see that a bit. But in the melanoma unit, we see a fair bit of this. Medical reassurance in error, someone looks at something quickly, "Oh, it's fine, okay." They biopsy a bit of it, biopsy part of the lesion, and the pathology report comes back. It'll mostly come back from good pathologists. They'll say, "Oh, not really happy, how about excising the whole lesion?" But occasionally they'll just say, "Oh, it's okay." And high-risk patients need to be followed up. A patient of mine, she's had 4 melanomas. She vanished for a couple of years. She was always coming in 4 monthly. She turned up, but 2 years later, thick melanoma in her ear, end of the story. Remember, a punch only gets you a little bit. Elliptical biopsy will get you a bigger bit of the lesion, but really it's better to excise the whole excise the whole lesion. This, because the pathologist needs the edge to make a sensible comment, you don't know really if you're going to get a cherry or not, do you? And that's what you've got to remember when you're doing a incisional biopsy. It's better to take the whole thing out like this, and that's it.
Thanks, Chris. I'll get Mark Lee now, plastic surgeon, to talk about sentinel node biopsy. I'm a Mac user, excuse me.
Good evening, guys. Mark Lee's my name. I'm a plastic surgeon based here at St John's. I've been with WAMAS for about 11 years now, since I returned from fellowship over in Oxford, where I picked up this technique, and some of the photos are from here. So, sentinel node biopsy's been quite a controversial topic in melanoma over the last decade or so, as probably many of you are quite aware. But hopefully, as I'll show you, the debate's changing a little bit at the moment. It's an extremely technically easy and very highly accurate procedure that can give us some very, very good information on melanoma, and possibly even impact on survival. For those that don't know, the theory behind sentinel node biopsy, originally we used to think that the lymphatic system was a bit like the venous system, and that lymph would go from into one vein, into one lymphatic, and then it could kind of go anywhere and end up, back in the central circulation. But around sort of 15, 20 years ago, we started to map the lymphatics and find that it was a much more structured and highly reproducible system. So the sentinel node basically is the first node that receives the lymph from a particular body part. And if we're talking about skin, one spot on your arm will go to one particular lymph node, and if you did a lymphoscintigram today and did one in 10 years' time, it would go to the same spot, assuming you haven't had any scars or other treatment there. Now, if it's a tumour, that can metastasise to the sentinel node and then disseminate to other nodes. Now, but it will always remain in that sentinel node. So you can biopsy the sentinel node, and that's reflective of the entire lymph node basin. And the theory is, if we can somehow do this test, remove it will reflect the lymph node basin, allow us to stage the patient properly and intervene the more appropriate therapies for those who need it more. And we use a combination of a radiolabeled dye with the lymphoscintigraphy to identify the sentinel node, and that's done by the radiologist. And then they come to the operating theatre, and we use the blue dye, the patent blue dye. So the three arms that we need to find it, the lymphoscintigraphy, the blue dye, and then during the operation I use a gamma probe, like a little Geiger counter that we can use on the operating table. So this is a lymphoscintigram. You can see the big black splodge there on the back of the head. That's where the primary melanoma was. So it's either a primary melanoma or a small biopsy site. And down from there you can see two smaller black splodges, and they are probably a first order node and then a second order node. But you'd need to examine this, look at this from different angles with the gamma camera. So a patient, if I'm organising for a sentinel node biopsy, the patient will go down to radiology, they'll have a lymphoscintigram, they'll come back to my operating theatre with an X marks the spot where the radiologist has marked the sentinel node. And if it's done within a few hours or even a day of the lymphoscintigram, the lymph node is still radioactive, so I can use the on-table gamma probe. Recently, we've been getting some fantastic images from the radiologists, and it's particularly helpful in the head and neck. The more difficult sentinel nodes that I do are ones from the head and neck region, where the anatomy, the lymphatic anatomy, is so much more complex, and lymph nodes can go to all sorts of places. But I can get some very good images from them now with the SPECT CTs showing lymph nodes, depth, where they are, and here's another one from a pelvic showing a deep node there. So patient comes into the operating theatre. First thing I do is a little tiny skin prick test between the toes while the patient's still awake before the anaesthetist puts them to sleep. And that's just a little skin test for anaphylaxis, because this is one of the things that we have seen. Certainly a lot of the breast surgeons would agree that the patent blue dye that we use here in Australia does have quite a high allergic and anaphylactic incidence. So small little skin prick between the toes, and by the time the patient's asleep, I'll then inject. So you see the biopsy site there, the marking site where the radiologist has marked the node. That's the old gamma probe that we used to use, but I'll show you the other one. Before the patient goes to sleep, you can run the gamma probe across where the X is, just to see whether the marker's changed or as the patient's been repositioned, but usually it's pretty accurate. That's the current one we use now, which can be sort of fully sterilised and used on table. Inject the blue dye just into the dermis, and then make a small incision over the site. And the gamma probe, particularly for deep lesions in the axilla or the groin, can be a very, very useful tool to just help me follow a particular tract and find, as you can see there, I don't know how well you can see it from the back of the room, but it's a small lymph node, but it's coloured blue, and when we put the gamma probe on that, it screams. And here's a little close-up view of a blue lymph node, and you can actually see the afferent lymphatic going into it. That's the central node. Put the node over the gamma probe and get a target count. And we're supposed to really take any nodes within about 10% of that target count, but I have to say most of the time, the vast majority of the time, once I've removed the sentinel node, I put the gamma probe back in the wound, and I don't get any radiation reading at all in most cases. So the criteria, who do we do this on? This is sort of the older criteria, though. You see, these are the criteria for the Sunbelt melanoma trial. So melanoma is greater than 1 millimetre, and with the MSLT trial was less than 3.5. So intermediate thickness melanomas are probably the most useful. Level 4 melanomas, ulcerated melanomas. I'm not so sure about this. I think that was more of a trial criteria. It wouldn't really. I can't really see that's an important criteria. That was again trial criteria. Now, initial excision less than 1 centimetre. This is quite important. So if the patient's already come with a very wide, they've had their definitive wide local excision, the sentinel node biopsy is probably not going to be accurate, because what you're biopsying is a much greater area and not the original area of which would lead to a sentinel node. And this is probably a pretty important exclusion criteria. So no previous surgery disruptive to normal lymphatics. So if a patient's got a melanoma on their arm and they've had a dirty great big incision or a huge flap or something higher up, then they're not going to get accurate lymphatic mapping. So the reasons to perform sentinel node biopsy, this is where all the debate and all of the controversy has been around for the last 10 years or so. We know that sentinel node biopsy is the most significant prognostic factor. It's very highly predictive of prognosis. It facilitates earlier therapeutic lymph node dissection. So rather than the classic watch and wait, examine somebody every 3 months for 5 years, and once they develop a lymph node the size of a golf ball, then you do your completion lymphadenectomy. Avoids elective lymph node dissection. Well, that's probably not really important these days. At the time this was all being developed, there was still probably a reasonable number of units that were still doing elective lymph node dissection for melanoma, but that's pretty much historical now. Interferon still, it can only be given TGA approved for stage 3 melanoma, but this is where we're getting into now that Tom Van Hagen's going to talk about later, which is, I think, the real game changer with Sentinel node. It's kind of putting a lot of this early debate about whether it's therapeutic or not, and to bed, because we're starting to get a lot more drugs that can be used as adjuvant treatments. Prognosis, the Journal of Clinical Oncology, Gershenwald, looked at a huge database of patients and looked at all these different prognostic factors and found that sentinel lymph node status was the most significant prognostic factor. And they're the curves. They're the negative patients, they're the positive patients. It's about 50%, that's about sort of 92%. And you can see it for the different sort of levels of melanoma. That's sort of everybody. That's 1 to 2, that's 2 to 3, 3 to 4, I can't read that, and that's greater than 4. And so there's quite a difference in prognosis between the two groups. Early therapeutic lymphadenectomy, again, I think this is becoming a little bit more relevant. There's so much debate has been on whether the sentinel node leads to a more long-term survival, those sorts of things. I mean, we know that big nodes, we know that matted nodes, we know that multiple nodes have poorer outcomes. It kind of seems fairly common sense that if you're taking the nodes out earlier, that before they've had the ability to become large and extranodal spread, that they would have a better outcome. But it's very difficult to prove that with the studies we have available. This is the big study that everybody's been talking about, and it's been quite controversial. The MSLT1 trial. So about 1,300 patients, 1.2 to 3.5. The sentinel nodes were about positive. The ones that had the sentinel node biopsy, they had about 20% positive rate, which is pretty standard across the world in all the studies that we've had. About 3 and a bit % were false negatives. So it's a very highly accurate test, 97.6 or whatever. No overall survival advantage has been shown, but a lot of the discussion about how the study was set up, and because there's only 20% of the patients that are actually sentinel node that will have node positive, you need about 10,000 patients here to actually show a survival advantage, and I'm not sure anyone's ever going to get to those sort of numbers, and I don't think it's actually relevant anymore. So this was the controversial one study, and there's still a number of interim analyses still to come. They're still publishing data. Around the sort of 4 years ago, they published this data. They showed that the node positive patients who had an immediate completion lymphadenectomy had a 5-year survival of around 72%, and those that had the watch and wait, and then when they developed nodes, had a 5-year survival of about 52%. These guys, 1.4 nodes on average. These guys, 3.3 nodes on average. Nodal relapse, around 3% nodal relapse on 15%, and a much higher morbidity on this lot because they had more extensive lymph node dissections and lymphedema, etc. So now, are these two groups the same? Well, this is what the MSLT guys like John Thompson over at the Sydney Melanoma Unit have shown. They say that these are the node positive sentinel node positive patients, so it's around 20%. Okay, and as the number of years go out from the study, the ones that we've been watching and waiting are gradually merging towards each other. So what they're saying is the same. If you wait long enough, the same people that you're watching and waiting will be the same numbers as these. If you add in the false negatives, they're pretty much exactly the same. Now, there's, acres of papers being written and discussions and things on that, but I think, for me, that's reasonably telling evidence when you look at those other figures. I think we are probably actually achieving something therapeutically with early lymph node completion lymphadenectomy. But this is, I think, what is changing the game now, and is going to make discussion on what I just mentioned before a little bit moot. Because of its such, it's the most significant prognostic factor. It's in the AJCC staging. pretty much all the multi-stage, multi-centre trials require sentinel node basin status as a prerequisite. And really, if we've got the sentinel node status, we're comparing apples with apples, the more specifically defined subgroup. Interferon I mentioned. Tom Van Hagen's going to talk about the trials available in Perth. Now, this was a fairly landmark paper that was published in August last year. It was a consensus statement put out by the American Society of Clinical Oncology and the Society of Surgical Oncology last year. Evidence-based, expert panel of about 14 sort of leading melanoma clinicians, and they looked at a meta-analysis of 73 studies. That was the surgical one, but it was also published in the Journal of Clinical Oncology. And this is their guidelines. So basically, recommended for all intermediate thickness melanomas between 1 and 4 millimetres. And it's interesting, they don't have an age cutoff in their recommendations. For thick melanomas greater than 4 millimetres, they recommended sentinel node biopsy for staging purposes and probably facilitate regional disease control. There's quite a lot of evidence that if you can pick up the node positive and do a completion lymphadenectomy early, you are going to improve regional control. For thin melanomas, this was quite interesting. Insufficient evidence for sentinel node biopsy, but some selected high-risk patients. So if you remember Chris's slide there on the, that showed sort of 100%, 100%, 100%, once you sort of hit to sort of 0.6, 0.7 millimetre thick, you start to get higher rates of positive sentinel nodes. For all melanomas less than a millimetre thick, it's about a 5%, but for that sort of 0.7 and above, if they're ulcerated, if there's high mitotic rates, you can get up to sort of 20% pickup rate. So the more high-risk patients, young patients, you might consider that. And with positive sentinel node biopsies now, completion lymphadenectomy, so taking the whole lymph node basin, is still a recommendation. Until we have the MSLT2 results, we're not really recommending just observation or ultrasound at this stage. So in conclusion, whether you think it's therapeutic or not, I think that's actually becoming a little bit irrelevant. A positive sentinel node, it's a marker of a significantly higher risk group who can then be targeted for further treatment or trials. And, I think the consensus is now that it's standard of care for intermediate thickness melanoma. I'm sure I'll still have a few people that disagree with that, but anyway, thank you very much.
Thanks, Mark. The next talk is on pathology, and I'll invite Ben Wood to come up and give us that presentation. Thanks, Ben.
Thanks, Mark. So I just wanted to spend a few minutes talking about some of the things you get out of a pathology report, sort of geared to people who don't see a whole heap of melanoma pathology reports. Just to sort of set the grounds of what area we're going to talk about, the first thing is that all of this micro-staging stuff that I'm going to go through applies to invasive melanoma. It goes without saying that in situ melanoma is a different scenario, but every now and then people do sort of get lost before they get to the starting line there. We're going to talk about primary cutaneous melanoma, and we're going to talk about the common sort of types of tumour. So all of the sort of strange, weird and wonderful variants that occasionally get sort of melanoma-type synoptic summary reports, we're not really going to discuss in this. And we're really talking about the issues that apply to mainly to localised lesions, so we're sort of excluding nodal positivity and stuff like that. So this is what a pathology report that we produce looks like, and from the various places they look slightly different, but the ideas are somewhat similar. And this is what we call a combined synoptic report, which includes, on the top, which I've cut out, demographic data, various sort of points, but really this part here, which is the summary, which includes the prognostic factors which we're going to go through and talk about individually. The first thing I'll just talk about is why we produce this kind of synoptic report. And this is a very important thing, I think, in cancer care generally, you know, breast cancer, colon cancer, many different cancer types these days, is that we're moving towards a system whereby all pathologists try and report these cancers using this combined synoptic report. Firstly, allows for complete sort of data to be accrued. So, you know, when you're dictating a report and you're sort of, you know, just talking about the lesion, it's easy to sort of, you know, forget something, somebody calls you at the wrong time, something gets left out. And there's pretty good evidence from multiple different cancer types that using a synoptic report ensures that the report is complete. There's obviously some benefits in uniformity of format and ease of interpretation, particularly in sort of oncology clinics and so on, where you're seeing a lot of people, you're used to seeing the report in a certain format, you know where to look for the various bits of information that you want to see. In the future, at some point when computing gets a whole lot easier, there's obviously potential for data linkage, and as part of that, the colleges of pathologists in Australia and the US and the UK are looking at a sort of program of international standardisation of these reports. So the report that we use for melanoma actually has a lot of similarities, and there's potential in the future for linkage with the reports in other countries, and there are obvious important things there. Just to give you an idea of how important this is a study which was published in 2010. The data was actually accrued in 2005, 2006 from New South Wales, from the cancer registry there. So we're not talking about a totally different place and a totally different time. And they looked at what percentage of the reports on their cancer registry actually included all of the essential criteria as they determined them to this study. And you can see that it's quite surprising that actually for excision biopsies, what percentage contained 100% of the essential criteria in the report, 17%. And we're not talking about little sort of, you know, strange things here. We're talking about Breslow thickness, Clark level, ulceration, margins, and look at the margin rates of reporting. So it's very important to know that without a sort of combined synoptic report, there's a big potential for incomplete reporting. So the first thing on the synoptic summary says the subtype of melanoma. And for the purposes of this discussion, we're talking almost entirely about superficial spreading melanoma, nodular melanoma, and melanoma arising from lentigo maligna, which is called lentigo maligna melanoma. Just an important sort of bit of terminology to be aware of. Lentigo maligna is an in situ process. Lentigo maligna melanoma means invasive melanoma. Those two terms are sort of very similar, so we'll often describe it formally as invasive melanoma arising from lentigo maligna, just to make it clear, because it's relatively easy to get confused between those two terminologic points. Amongst these sort of common subtypes, when you adjust them for the other prognostic factors, the subtype is not of particular prognostic significance. One of the more interesting things is that there's emerging evidence that these traditional sort of Clark subtypes actually sort of correspond to the genetic changes. So the tumours which occur in sort of truncal areas in young people with limited sun exposure tend to be more often the ones that are superficial spreading type and associated with BRAF type abnormalities versus, say, c-KIT mutations in the lentigo maligna type that arise on severely sun-damaged skin. So as we move in probably the next couple of decades towards a molecular classification of melanoma, we might see that this sort of subtype actually has more relevance than perhaps we thought it had 10 or 15 years ago. So what is the Breslow thickness? Well, it's basically just a measurement from the top of the granular layer to the deepest invasive melanoma cell. And so here's a melanoma that's a little bit less than 0.7 of a millimetre thick, and that's how it gets measured. If there's ulceration, we measure it from the base of the ulcer. And as has been already mentioned, the Breslow thickness in a primary melanoma is the critical prognostic factor if you had to choose one. And as was already seen from those other slides, the Breslow thickness is a continuous sort of relationship with the mortality or the outcome, so that although we sort of divide these at 1 millimetre and 2 millimetres and 4 millimetres and so on, actually the prognosis of a melanoma that is 0.3 millimetres thick is extremely good indeed, somewhere down here, whereas, you know, up to 0.8 or something like that, it is slightly worse. The second factor which will be sort of listed on the synoptic reports is the Clark level. And obviously, to some extent, this gets to some of the same information as a Breslow thickness. So a thin melanoma is typically going to be a Clark level 2 or 3, and for the purposes of this, we're excluding Clark level 1 because that's in situ. So a thin melanoma is typically going to be Clark level 2 or 3. whereas a thick melanoma is usually going to be Clark level 4 or 5. And so there's clearly some overlap with the Breslow thickness. And once you start adjusting for thickness, also for the presence of ulceration, and in some of the more recent studies where they've included mitotic activity, the importance of the Clark level diminishes somewhat, to the extent that in the new sort of staging criteria we no longer use it to subdivide the T1 lesions. However, all of that data is still relevant in the sense that if you have, for example, a Clark level 2 melanoma which doesn't have regression, the chance of developing metastasis from that is extremely low, perhaps even negligible. Conversely, if you have a melanoma that is thin, in inverted commas, less than a millimetre thick, but it happens to be one of those ones that is actually Clark level 4, that's still an adverse prognostic factor. It's just that when you look at it statistically, it falls away in importance as you adjust for those other criteria. Ulceration is either the second or third most important prognostic factor after Breslow thickness, and clearly ulceration is an adverse prognostic finding, and it probably tells you something about the way in which the tumour is growing in terms of its ability to sort of push away and eat up the epidermis, but also it's obviously not independent of thickness, and this is a fairly obvious ulcerated thick melanoma here. Going through here. So it's an important negative prognostic factor. Importantly, it's definitionally non-traumatic, and this is where people taking biopsies have a little bit of a sort of a role to play. One of the things that's most difficult to separate from non-traumatic ulceration is traumatic ulceration previous biopsy. So if a melanoma has been biopsied and the pathologist is unaware of that, then it's quite easy for that to be mistaken for ulceration in some sort of circumstances. Sometimes we can histologically separate them, but not always, and it's easier if it's just said on the request form that it was previously biopsied. And so ulceration stratifies all the T categories, which are divided by thickness, into A and B. And you get an idea of the importance of it by looking at this graph, which is a little bit busy. But basically what this graph shows you is that for T1 melanomas, these are the non-ulcerated lesions. The ulcerated lesions group here with the T2 lesions, and so on. For the ulcerated T2 lesions, they group with the T3 lesions, and the ulcerated T3 with the T4s, and so on down. So basically ulceration moves you closer to the behaviour of the next T stage up. Mitotic rate is assessed by looking at a 1 millimetre area of tumour in the dermis, and basically the pathologist looks down the microscope, finds the busiest area of mitotic activity, and then counts the mitotic figures in that area. And they tend to be, in these thicker melanomas at least, clustered in sort of hotspots of mitotic activity. And that's reported as a rate per millimetre squared. The most important thing for mitotic activity is that the difference really lies between melanomas that don't have any mitoses and melanomas that do have mitoses. Now, sure, it's worse to have more mitoses than fewer, but actually really the split lies between those that have no mitoses at all and those that have mitotic activity. And actually a big study from the Sydney Melanoma Unit showed that it was really probably the second most powerful prognostic factor after Breslow thickness, or perhaps equal to ulceration, depending on how you look at the data. In terms of staging of melanoma, the presence of mitotic activity is one of the criteria that we use to separate them into T1A and T1B. So as you remember, for those melanomas that are less than a millimetre thick, if they have ulceration or mitotic activity, really they're more like the T2 melanomas in terms of their outcome and behaviour. Satellite metastasis. So this is, at some level, getting away from the idea of localised primary cutaneous melanoma. So here we're talking about a melanocytic tumour here, melanoma invasive down into the subcutis, and here you can see there's a separate deposit sitting away from that lesion, separated by normal dermal tissue. There are a whole heap of terms which have been used variably in different studies over the years. So some people talk about satellite lesions, some people talk about microsatellite lesions, in transit metastases. They have different sort of definitions which are kind of boring and not particularly relevant. The reality is that they all probably represent the same process, that is, spread through lymphatics to a site sort of adjacent to the tumour. And really there's no difference in outcome between them. And just for sort of staging purposes, it's important to remember that satellite metastases are not nothing. In fact, they shift you up into the equivalent of nodal positive disease, so in the sense that they are reflecting that spread. So satellite metastases without nodal involvement is actually N2C category. So satellite metastases are a bad prognostic factor. This is just how we T-stage the melanomas, and really this is just a synthesis of the information that I've been talking to you about. So we've seen that they're stratified by thickness, less than 1 millimetre, 1 to 2, 2 to 4, and greater than 4 millimetres. And in each of those stages, the presence of ulceration shifts them up into the B category, with the additional sort of feature that for tumours less than 1 millimetre thick, the presence of mitoses is also sufficient. On the synoptic summary that we use, there are a number of other data points, and to be honest, some of this comes from the sort of research interests of the people at the Sydney Melanoma Unit and other places who have sort of pushed this stuff. There's no doubt that they have prognostic features in various studies, but they're probably secondary from the point of sort of clinical management. But what we do include tumour infiltration by lymphocytes, which is sort of thought to be an active immunologic attack on the tumour. Regression, which is sort of debatable but generally considered to be an adverse prognostic factor if you've got established regression. Certainly if you look at people with thin melanomas, so those Clark level 2 melanomas, the ones that develop metastases, which is uncommon, are almost always the ones who also have the presence of regression in that sort of setting. Lymphatic vascular space invasion, fairly self-evidently an adverse sort of feature, and perineural invasion, quite uncommon. But when it's present, an adverse feature. And usually we see that in the setting of desmoplastic melanoma, which can be a very sort of difficult disease to manage in terms of local recurrence, and difficult to sort of extirpate locally. Margins is a very big sort of topic. It's fairly evident that involvement of a surgical margin can result in sort of regrowth or metastasis from any residual tumour which has been left behind. We report the margins as three separate measurements. The first one being the peripheral margin to the in situ component of the tumour. Obviously, that comes most into question in the sort of setting of lentigo maligna, and the nature of that lesion is that it tends to grow diffusely and spread sort of, often beyond where it's clinically apparent, and often can be quite a difficult sort of microscopic matter. We also talk about the peripheral margin to the invasive component and the deep margin to the invasive component, which are usually more clear-cut. The only point that I want to make, because we could talk about margins for an hour at least, is that we shouldn't conflate the clinical margin recommendations. So you look in your NHMRC guidelines and they'll give you recommendations for a centimetre margin or a 2 centimetre margin or whatever. That is not a pathological margin. What a clear pathological margin is a topic unto itself. But most importantly, I think, is to get across the idea that because the clinical guidelines say a 2 centimetre margin and you get a pathology report saying it's 12 millimetres clear, that's not necessarily an indication to go back. A 12 millimetre pathological margin is almost certainly going to be a clear margin. So we shouldn't sort of conflate clinical recommendations and histological measurements and think that they're just equivalent. The last part is usually a description of the tumour, and in these more difficult cases a rationale for the diagnosis, and any discussion of the difficult issues. So that's basically taken you sort of step by step through the points which you should see in a melanoma sort of synoptic or combined synoptic report. The important take-home messages being that really the primary piece of information for a melanoma and a primary melanoma is the Breslow thickness. Ulceration and mitotic activity are very important. Clark level is also important. The margins obviously go to therapy, and a lot of the other stuff there is of less sort of direct clinical relevance in most sort of circumstances. And if anybody has any questions or wants any references to those papers or whatever, I can send you PDFs.
Thanks, Benjamin. That was great. The next paper is from Tom van Hagen, one of the medical oncologists with our clinic, and I'll invite Tom to come up and speak. Thanks.
Thanks, Mark. Welcome, everybody. Thanks to the other speakers. I've learned quite a lot tonight. I'm Tom van Hagen. I'm a medical oncologist here at St John's and at Royal Perth. I've been asked to talk about the trials that we're doing in Perth at the moment, of which we have a number of very exciting ones. To be honest, it's about 3 slides and takes 2 minutes. So the more exciting thing to talk about tonight is how we got to the drugs that we're currently looking at. So just to put things into perspective, before August the 1st of this year, the last drug to be PBS listed for melanoma, called dacarbazine, came about when I was 4 years old. And we've been using the same drug for the last 40 years until really in the last couple of years, but only to be prescribed in the last 2 months. So I just, a bit of a sitter for melanoma there by the looks of it. I'm blonde and fair-skinned. But... Thanks. So dacarbazine is a drug we've been using, and the trials for it have never shown any improvement in survival in melanoma. So we've been offering a drug to patients for 40 years that won't affect their outcome. And the response rates I generally used to quote as about a 1 in 10 chance of it working. So it's pretty miserable looking after patients with metastatic melanoma. I just want to add a caveat to that drug, say that only in America have they been using interleukin-2 over the years. We don't use it in Australia. It's an extremely toxic drug with mortality of up to 10% of its use. But the importance of it is really this graph, where although the majority of patients don't do well, there are long-term survivors. Up to 20% of patients are living for 5 to 10 years and are potentially cured with this immunotherapy, and that's really where we're moving on in melanoma now. So what's just happened in the last couple of years is just a massive burst of new drugs on the scene. And just 2 years ago, 2 drugs were developed and TGA approved in Australia, and I'm sure most of you will have heard of them. One is called vemurafenib, which is a targeted therapy, a BRAF inhibitor, and the other is ipilimumab. Takes us months to learn how to pronounce these names, by the way. But that's more of an immunotherapy. And they were both approved, and we've been using them here for a couple of years, usually through access schemes on the drug companies. But then since then, we've had 2 newer drugs, another BRAF inhibitor, another drug called a MEK inhibitor, and we'll talk a bit about that in a minute. And then just this year, some very exciting drugs coming through. Again, these drugs are immunotherapies. PD-1 stands for programmed death, and it's all about stimulation of the immune system. So we'll talk in a little bit of detail about that, but I'll probably just concentrate on the vemurafenib and ipilimumab that we've been using. So we've moved away from chemotherapy for melanoma now. It's very rarely used, except when we can't get access to the drugs, and we now base our treatment on whether it's immunotherapy or targeted therapy. And just have to talk about a little bit of science now, but what is the target for melanoma? It's what we call the MAP kinase pathway. So from the cell surface, there's a number of steps, and as you can see, BRAF is one of the important ones, that if you have a mutation in any of these steps, it leads to activation of the melanoma cell and growth. So we're targeting these pathways, try and block them and turn off the cancer cell. Now this is vemurafenib. It's an oral therapy. That box costs about $3,000 and lasts for about a week or 2. But this is the MAP kinase pathway that I was talking about. So if you have a BRAF mutation, that leads to down regulation of the MEK and ERK, turns the cell on, leads to proliferation. And then vemurafenib comes along and blocks that. And then leads to down cellular disproliferation. So the trials for this drug came about extremely quickly. I've never seen it move quite so quickly. I was around when the phase 1 trial happened just about 3 years ago, and everyone got very excited. I think it was actually 14 patients. And I'm sure you know phase 1 trials, the patients have usually been pre-treated up to their eyeballs, and virtually every patient responded. So it moved on very quickly to BRIM2 and BRIM3, and I'll just concentrate on the phase 3 trial, which was comparing vemurafenib to awful chemotherapy, dacarbazine. Just to talk quickly about BRAF, it happens in about overall 50% of the melanoma patients. Ben mentioned it's more common in younger patients. It's much more common in younger patients. They have a different type of melanoma than our older patients, but overall it's about a 50-50 chance of having a BRAF mutation. And just prior to this, no other trial of any drug for melanoma has ever shown any response rates greater than 20%, and essentially nowhere near that. And this, it was a large trial, nearly 700 patients, half went on to vemurafenib, half went on to dacarbazine. And this is what we live for in oncology, is our survival curves, and generally when we're looking at a new treatment, we're very happy if we can get a finger between the two lines, and this is probably one of the widest ones I've ever seen. You get your whole hand through. So the response rates of vemurafenib were very high. The overall survival was still good. You get two fingers between there. But the problem with vemurafenib is it doesn't last for as long as we'd like. But when we talk about response rates, we're talking about at least a 30% reduction in the size of the tumour. And in this study, at least half the people got that. But if you look at any type of response, this is what we call a waterfall plot, you can see that compared to dacarbazine, virtually everybody responds to this drug. It's about a 90 to 95% response rate, which is just absolutely remarkable for us in melanoma. This is just an example of somebody absolutely riddled with lung metastases and nodal metastases. And they've had almost a complete response, and this often happens within 2 or 3 weeks of being on the tablets. It does come with its toxicities, but actually it's extremely well tolerated generally. It's mainly skin toxicity, and sunburns are a major problem. I warn every one of my patients not to go in the sun, and they all come back saying they forgot and often have something looking like this, and then they don't do it again. Just a few minutes in the sun. And the other interesting thing is they're much more prone to developing squamous cell carcinomas, and up to 20% of patients will develop a squamous cell carcinoma, which obviously are much more treatable and usually very treatable locally. So the conclusions of that trial, the main ones were really that it was the first drug ever to show an improved response rate, progression-free survival, overall survival in the time we've been treating melanoma. And probably their last conclusion is very relevant to what we're about to talk about tonight, is that it's just a sort of foundation to build upon new drugs, either with it or similar to it. And this is really just an example of what's happened since then. This is that MAP kinase pathway I was talking about with vemurafenib in there. But we now have other BRAF mutations, BRAF inhibitors, what we call MEK inhibitors higher up, c-KIT inhibitors, and the combinations seem to be much, much better than the single drugs alone. And then to move on to immunotherapy, which is even more exciting, and it is potentially going to lead to a cure for metastatic melanoma, which I find quite amazing to say out loud, but it really is true. So this is an intravenous infusion, and again, just a little bit of science. When an antigen comes across to a T cell and the antigen-presenting cell stimulates that T cell, unfortunately, there's a molecule called CTLA4 which comes into the T cell to turn it off, and that's what we want to prevent. We don't want the T cells turned off, we want them activated. And you can kind of imagine it's a bit like a vaccine. If the T cells are still stimulated, you've got memory T cells to sort of vaccinate against your tumour. And ipilimumab, not surprisingly, is a monoclonal antibody that blocks the interaction of CTLA4 and the antigen-presenting cell. So the major trial that came from ipilimumab, it wasn't the best designed trial in the world. They actually used it with the chemotherapy, which they shouldn't have really done because it turned out to be a bit too toxic. But the bent of this trial was looking at the survival of patients after treatment, where prior to any of these drugs, you had a 1 in 4 chance of living for longer than a year with metastatic melanoma, and a 1 in 10 chance of 2 years. And this graph really, it's not quite the graph from the trial, but anyway, it shows the point where what we're seeing is a very similar line to that interleukin line that I showed earlier, where you're having a plateauing of survival of 20% of patients living for 5 years. And in fact, just on the way here, I got emailed today an update of this trial, which the first patients have been shown are still alive at 10 years. So the assumption is those patients are probably cured. This is looking at those survivals at year 1, 2 and 3, and you can see that significantly higher with ipilimumab, but at 3 years, 20% of the patients are still alive with metastatic melanoma. And the main thing to get from this is that the response rates are not good. So the vemurafenib response rates officially were 50%, but actually about 90% of people respond. This is not too different to the dacarbazine. You only get about 15% of people responding. But when they do respond, in the bottom line there, their response is often for a couple of years or more. And again, it doesn't come without its toxicities, and in fact, a bit more unpredictable with ipilimumab, and it can be quite a tricky drug where you can lose control of some of the patient's side effects from a sort of immune burst, and all of these side effects are due to immunostimulation. And they're all treated with immunosuppressants, usually with steroids initially, but occasionally we do need some of the TNF blockers and things to get people out. So there have been fatalities reported with this drug. So the main conclusions of these two sort of pathways are that up to this point, the BRAF inhibitors were great, but they just didn't work for as long as we liked. And ipilimumab doesn't work in as many people as we like, but it does seem to go for a long time when it does work. And currently, I've got a number of patients on both these drugs. Unfortunately, vemurafenib did not get PBAC, get through the PBAC, and it's unlikely to, probably because we're developing better drugs than that, but it is disappointing for the patients with a BRAF mutation, hence all the trials that we're doing. And ipilimumab, amazingly, was it's on the PBS now, despite its huge cost. So for an average-sized person, an infusion once every 3 weeks costs $30,000. We do at least 4, and then we often repeat that, and it can cost up to $250,000 a year or more. So what next? And obviously we're getting on to sort of this year. As I mentioned, the BRAF pathway has improved, where if you block both BRAF and MEK, you're getting the amazing responses, but they seem to go on for longer, not 6 months, maybe a year or 18 months, still not quite as long as we'd hope. But as you can imagine, also what we're trying to do with these things, because the response rates are so good, what we want to do is use them at a time when we might be able to cure patients as well, and that's the adjuvant setting that Mark's talking about, where we may well be able to alter the outcomes. And it sort of brings us on to the most recent data, which has just been a buzz around, and a paper in the New England Journal a couple of months ago that's been in a number of other scientific journals. I think I was asked 8 times today by patients about it. And to be fair, it's extremely exciting. It's a trial based on 52 patients, but nonetheless, it's bringing together everything we've just talked about. And again, just a little bit of science. It's not dissimilar to the CTLA-4 blockade, but the T cells also want to die with what they call a programmed death receptor, which is quite cool, I think. But what nivolumab does, this is a new drug, it blocks the PD-1 receptor, and again, hopefully to keep the T cell going, keep the memory going. And that PD-1 receptor binds to what they call PD ligand, and they're developing PD ligand inhibitors as well. So it's all coming together. And really this study and this waterfall plot combines those two things we just talked about, which is excellent response rates. So this was 52 patients, 42 of them got some sort of response. That's very different to the ipilimumab. And half of them got at least 80% shrinkage of their tumours. And again, one can just envisage that a lot of these patients may well have long-term outcomes and potential cure. So that brings me on to my talk, which is current trials in WA and how to get your patients in. So I work at Royal Perth. As you probably realised, anything with BRIM in it has something to do with vemurafenib, BRAF inhibitors in melanoma. So we've gone on from BRIM 3 and we're now on to BRIM 8. So this is the adjuvant trial looking at patients with a BRAF mutation who have positive lymph nodes, and that's really where Mark's discussion about sentinel lymph nodes is extremely pertinent, where you could argue sentinel lymph nodes don't change somebody's outcome, except if you have a drug that can cure them or improve their cure rate, and one envisages that a drug that has a response rate of 90% has a very good chance of killing micro-metastatic disease. So that trial has recently opened. It's very difficult to get patients on. They need a colonoscopy, an ENT review, a dermatology review, colposcopy, just any orifice that anyone has needs looking at. But we, in a very short time, but nonetheless we are managing to get a patient or two, aren't we, Caroline? Anyway. And then COBRIM is for the metastatic patients, and this is looking at the vemurafenib that we talked about and comparing it with the BRAF inhibitor, and that's a MEK inhibitor, and really trying to prevent the tumours becoming resistant. And then at Sir Charles Gardner Hospital, they have 3 trials. They also have an adjuvant trial looking at BRAF inhibitors, but with the MEK inhibitor, and one could argue that that trial might be better than a BRAF inhibitor on its own. I'm not sure we can say for sure, but nonetheless that is slightly in contrast to the trial we have at Royal Perth. But what Charlie's do have is the exciting trials from my point of view, which are the immunotherapy trials, which is ipilimumab with a PDL1 inhibitor, and that trial really that I just talked about, with or without nivolumab, or with nivolumab on its own, and that's a first-line trial. And I personally, if I have a patient who does not have a BRAF mutation, I refer them straight to see Michael, because if I had metastatic melanoma, I would want a chance to be on that combination drug. Basically, to contact either myself or Michael Millwood. There are other oncologists who deal with melanoma, but I'll be very happy to take any calls. And Hema and Caroline are our managers. So, thank you.
Thanks, Tom. And let's not forget, another probably easier way to get patients into the trials is send them to us at WAMAS, because of course both the Royal Perth and the Charlie's oncologists are at WAMAS, and your patients will automatically be suitable for consideration at the WAMAS panel because they have metastatic disease. So if you didn't get down those numbers, then you can just contact Julie, get the patient seen by us, and they can be entered into the most appropriate trial. I'd now like to invite Christobel Saunders, who, for those who don't know, is an oncological general surgeon who works predominantly at Royal Perth Hospital, but also here. Is that right, Christobel? And Christobel deals mainly with breast and melanoma, and she'd like to talk about the benefits of a multidisciplinary approach with management of melanoma.
Thanks, Mark. Well, guys, we're nearly over, so big breath. Nearly the end, and a lot of what I'm going to say is kind of pulling together what other people have said and repeat. So I don't apologise for that, because hopefully it'll come clearer towards the end. Just briefly, I'm amazed nobody's mentioned the statistics of melanoma in the States, so I'm glad that I put this slide in. This is the latest figures from our cancer registry. Melanoma is now number 3 in terms of malignancies in WA. 1,115 new cases in 2011, although there were a number of second melanomas in people who'd had them before, and 1,500 in situ melanomas, which are now in the cancer registry, have not been in previous times. 60% in men. It gives a point prevalence of around 1 in 2,200 of the population, and I guess pleasingly, relatively few deaths, so 134 in men and 46 in women. And in really everybody, survival seems to be great and fantastic and improving, apart from in older men. And that's a rather worrying trend that older men seem to be getting more melanomas and dying more as well. And so that's something that I think all of you guys out in general practice land need to be aware of, that we do still need to look at our older men. And I'm very grateful, as always, to Dr. Quirk for fantastic pictures. So you don't mind I've stolen some of your lovely pictures. You've seen this before, haven't you? The thickness determines prognosis, and I guess that's the important thing in older men, that they do seem to present with thicker melanomas and therefore worse prognosis. Now, I've been asked to talk about multidisciplinary care, so I thought I'd just start to talk about that generally in cancer, because it's a subject I think is very close to my heart and is really important. I mean, we all know that cancer treatment can be very complex, involve lots and lots of disciplines. So really, multidisciplinary care represents that. It's an integrated team-based approach to looking after patients, where you have both the medical professionals, allied health professionals, that will consider all possible treatment options and develop a treatment plan for the individual patient. Now, obviously, the composition of a multidisciplinary team is going to depend on what kind of tumour type it is. And you've already heard a bit about the melanoma team and who's in it. Also, the structure of MDTs varies. So many MDTs are actually based at individual hospitals, where they will perhaps be the only hospital that looks after that kind of cancer, like a sarcoma, for example. Or, for example, in breast cancer, many of the major hospitals will have a breast cancer multidisciplinary team, both public and private. If we're out in the country, the multidisciplinary teams will talk about all cancers. So I was on the Midwest one, as was Tom this morning, where we talk about any kind of cancer that comes up to Geraldton. But we do know that multidisciplinary care is recognised as best practice, and that's because there's evidence. There is some evidence, I have to say not huge, but there is some evidence that patients looked after in multidisciplinary teams have better survival. I think there's good evidence that they have better quality of life because they have more appropriate treatments. Also, the decisions made by multidisciplinary teams are much more likely to be in evidence-based, according to guidelines. And I think the two interesting points is that patients tend to be happier when they're looked after by a multidisciplinary team. There's certainly less legal cases by patients looked after a multidisciplinary team. And even the mental well-being of the clinicians who work in it is better than those solo practitioners. You know, the old days of a general surgeon working by himself and never talking to anybody else except perhaps in the corridors, I think is largely gone. So multidisciplinary care is about working in teams. It's also a little bit about volume. There is some evidence that for at least complex cancer cases, higher volume specialists will have better outcomes. It certainly does always include that idea of a case management meeting and having appropriate models of care. So that whole team has sat down and thought about the best way that patients should be treated. An outcome audit system is really important, that we know what our results are. Otherwise, there's no point in us treating patients unless we know we're actually doing better by them. That team, as I said, can be very variable, depends on the cancer, but it should include not just medical specialists but others, and also remembering all of our diagnostic specialists, you know, our pathologists, our radiologists. And I think there has to be a leader of a team, and it's not always a surgeon, but it often is a surgeon. So you'd think it would be a no-brainer. I mean, why isn't everybody in this country with cancer looked after in a multidisciplinary team? And I've just put one little piece of work that we did a few years ago when the National Breast and Ovarian Cancer Centre was still alive, before it became part of Cancer Australia. And we surveyed 155 hospitals. And I guess the bottom line is that we found that only only one-third actually had a multidisciplinary team for cancer, which meant two-thirds did not. And the way they functioned was really pretty poor. Now, these did include a lot of rural hospitals. Metropolitan hospitals were much more likely to have multidisciplinary teams for cancer, and we looked only at the 4 big cancers, not actually at melanoma, but the same would apply for melanoma. So we're not doing that well. So you've already heard this, first off from Mark Hanikeri about what our team does here in the Melanoma Advisory Service. We have the pathology review, we have the clinic where we see patients, and then we also have the meeting where all of us sit around and monthly and discuss all of the cases and come up with a treatment plan or refine the treatment plan that's already been discussed. And this, to me, is what a multidisciplinary approach is. It has the patient at the middle, and then it has everything else around the outside. But it can be complicated. This is the gynae oncology here in WA service. Now, you can't read any of that. I shudder to think how patients find their way through that. And I have to say, Julie, you are probably one of the key people in this service, because it is often the nurse specialist who gets patients through. It's not as bad in melanoma, but it gets them through that kind of patient journey. I also think it's important to mention that melanoma shouldn't just be discussed in an MDT, but we do then refer, as Mark said, refer patients back to the referring doctor to be treated by whoever you feel appropriate, and that's fine. But I do want you all to reflect on the fact that I think it is better if a patient can be treated by somebody who is at least used to treating melanoma. Clearly that's not necessary for thin melanomas, for good outlook patients, but there's really is important for the more complex melanomas. There's not much evidence about outcomes. There was one interesting study from Michigan where they took 104 patients treated in the main Michigan melanoma multidisciplinary service in the main teaching hospital, and 104 patients treated in small community hospitals by non-specialists. And the one thing they did find was it was a lot cheaper to be treated actually in the main centre because there were less unnecessary procedures and less morbidity. Certainly in other cancers, there's really good evidence of better survival outcomes for patients treated by specialists. And I haven't put the breast data up. I could give you a whole lecture about that. So I've just put up some other data about other cancers. But there's other reasons, and you think, well, why is that? I mean, surely, any surgeon can take off a bit of skin, really, and sew it back together. But it's probably not necessarily that. It might be due to the complications. That's one reason we think, and there's some good evidence to show that patients, when things go wrong, are much better treated by specialists in a specialist centre. But there's other reasons as well. The patients who are treated by specialists are more likely to have access to the latest diagnostic techniques, whether that be PET scanning, molecular biology, those novel optical techniques that Chris was talking about, that's optical coherence tomography at the bottom, could be a number of other tests. Access to the latest surgical techniques, you heard about sentinel node biopsy in detail, some good reconstructive surgery, isolated lymphofusion, whatever that technique is. The treatment options, certainly, that you heard about just now from Tom, which I thought was inspiring. I mean, it's so exciting that we can actually give drugs that work. But also specialist radiotherapy, specialist nursing services, good patient information, good information back to the referring practitioner, psychological counselling, all of which is available from WAMAS, specialist physiotherapy, really important for patients having nodal dissections, and a good follow-up plan, if nothing else, to look for second melanomas. And finally, access to clinical research, access to all of those trials that Tom's been talking about, but also biological trials that are the basis of actually how we find out what drugs work, keeping a good registry of melanoma patients so we know our outcomes. We do tend to follow guidelines, and Mark put up some of those local guidelines, and we follow those for good reasons, because there's no way all of us will be able to keep up with the literature. Apparently there's nearly 2,000 new medical articles a day published. And so really a guideline aims to bridge that gap between research and practice and really make us understand, and reduce variations, reduce bad practice. We also think guidelines actually improve morbidity and mortality and improve quality of life. And they certainly mean that all patients get treated equally as good, we hope. Now, some people whinge about guidelines. Some people say, oh, well, it's just medical laziness to, it's reading a cookbook and, why bother to do that? And they do have a shelf life, admittedly. Whenever you write anything down, by the time you finish writing it, it's probably out of date, especially with medical treatment or medical oncology treatment of melanoma. They're incredibly expensive to produce, and it seems that every country has to have one. There has to be the sort of, the Zimbabwean guidelines for treatment of melanoma or whatever. Is that appropriate? I don't know. But I still think there's good evidence that we should use them. So on to the second and final bit of what I wanted to talk to you about, and Mark has largely alluded to this, so this is really just pushing that message home. Who should you refer to a multidisciplinary melanoma service such as WAMAS? Well, I think anybody with a melanoma thicker than 1 millimetre, Clark's level 4, or possibly, as Mark said, thinner melanomas that have got special features, that have got a lot of adverse ulceration or other features. Certainly you can talk to the service about that. And it allows those patients to have discussions like Mark Lee was talking about, sentinel node dissection. I think melanomas at unusual sites, gynae, head and neck, mucosal ones, could probably do with coming to us. I think, Mark, you'd agree with that, at least for a discussion. Certainly if you think the patient's eligible for a clinical trial, as you've just heard. A patient with multiple primaries, I think, is worth referring to the Melanoma Advisory Service. Certainly children should be a special case, and we do see a number of teenagers with often very odd pathological lesions, Ben, aren't they? They're not straightforward at all. Certainly metastatic disease or local recurrence, it's worth referring to WAMAS, and complex surgical issues. So those complex cases that Mark had mentioned, for example, on the face, near the eye, and things like that, that you may not just want to remove in a local general practice or skin clinic. High-risk patients, we've already heard a little bit about that from Chris. I don't think most of these probably need referring to WAMAS, but it might be worth you referring them perhaps to a dermatologist for a specialist opinion. The lesions of uncertain malignant potential, such as a multiple nevi or dysplastic nevus syndrome, patients with a strong family history of melanoma. We do know there are some genes associated with this. You can refer them to genetic services. They won't test for them at the moment. But nevertheless, you can discuss it with genetic services. And then I think the other ones, patients with previous melanoma, they're at high risk, but they need a watch, but who is quite capable for general practitioners or others to do that. And of course, the high-risk patients who are fair and sun-damaged backs. So just the final two summary slides. Multidisciplinary care is really a team approach involving all the core disciplines plus allied health with other specialities as required. Really, the important thing is good communication between everybody and the ability for all patients to have access to a full therapeutic range, no matter where they live and no matter where they're treated. That we do use guidelines to guide our care, that we do audit our outcomes so we know what we're doing. And lastly, and really importantly, that patients have the opportunity to discuss those decisions about their care. And who to refer, briefly, well, I think just as a guideline, anybody with a thicker melanoma over 1 millimetre, with adverse pathology, an unusual site or an unusual patient, and metastatic or recurrent melanoma. Thank you.
That's great, thanks, Christobel. I'd like to now invite Ross Taylor to speak. Ross has kindly agreed to step in lieu of Clint Hill, who was the founder and director of Melanoma WA. Ross, I'm told, is also with Melanoma WA. Is that Ross? Is that right, Ross? And I understand has also had melanoma in the past himself. Okay, so I'd like you to welcome Ross Taylor to the stand. Thank you.
Thanks very much indeed, Mark. And as you've heard from Mark, my name is Ross Taylor, and I should just add that if you can remember the name Ross Taylor, because the good news is if you Google Ross Taylor cancer, you'll get everything you need to know about my journey with metastatic melanoma. But if you forget to put the word cancer in with it and just put in Ross Taylor, I hope you like cricket, because you'll end up with 21 pages about New Zealand cricket. So I'll leave it up to you which of the two that you'd like to do. But as Mark has indicated, with myself, apart from my family commitments, the two things that keep me pretty well occupied on a day-to-day basis these days is spending most of my time as a commentator talking to politicians, government and most of the media outlets about issues concerning asylum seekers in Indonesia and Australia. The other thing I happen to do as part of my day job is, and I've been doing it for 20 years now, is keeping myself holistically really, really well. Because 20 years ago I was diagnosed with metastatic melanoma at the age of 42. Do a quick calculation, you can work out I'm 62 now. And that was whilst we were living in Singapore. The primary was never found, and the metastases turned up in the left lymph glands. And it was interesting back then, and one of your speakers referred to in those days, of course, the treatment was pretty standard, wasn't it? I guess as a patient it was surgery, chemotherapy, and extensive, I think about 24 regimes of radiotherapy over here in Salvado Road. And as many of you would know, back then particularly, the prognosis wasn't really that good. But one of the things that was interesting at the time was that, and I'm sure you find this with many of your patients, is that both my wife Catherine and I were really happy with the relationship with our dermatologist, doctors, surgeon. But of course, we just wanted to do something ourselves to contribute to the journey. And I found that, and I'm just feeling that many of you are probably placed in this situation, that when doctors are not confident to refer patients to, if you like, outsiders, one of the real problems happens, and I've seen this in 20 years as a patient, in the absence of that advice from you people, they go and search for themselves and they go and look. And that's what I was doing, and it takes you into the world of, if I can use that word, the loopy brigade. And, I had people telling me about I can cure melanoma by putting magnets on my toes and $10,000 for this machine. I guess you've heard all that before. And I often said to my wife, back in '93, wouldn't it be great if the doctors felt confident enough to know that somewhere there is an organisation who can pick up on all the things that they just don't have the time to cover in terms of mentoring, not necessarily counselling, but mentoring, meeting other patients, help for my wife. The carer just gets forgotten about so often by everybody in this process. And I thought, wouldn't it be great if there was such an organisation? So I'm really pleased to tell you that WA has such an organisation now called Melanoma WA that was founded by a young West Australian of the Year, Clinton Hill, about 3 years ago, the Melanoma Cancer Support Association of WA. Clinton, at the age of 22, was first diagnosed with metastatic melanoma. He's 29 now, and I think he's just recently had, and he doesn't, I've asked him, he tells me I can say this, I think it was his 34th metastatic melanoma removed. I had one. So this is quite a remarkable young man. But I just wanted to tell you in the couple of minutes I have got about Melanoma WA. What Melanoma WA is not about is trying to take patients away from their doctor or the medical process. It's not about providing alternatives. In some respects, it's actually not even about complementary therapies. So what is it about? It's about what we call lifestyle choices. It's about providing an environment for melanoma patients and their carers to come to meet other people on that journey. And I know myself, when I was able to meet people who also had melanoma that were, say, 4 and 5 years out, to me that was just fantastic to be able to talk with them and exchange ideas. So we provide that forum. We do an awful lot of work in terms of telling people about the importance of early detection of primary melanoma. Clint spends a lot of time up in the northwest with the mine workers, and we continually, and Julie knows this too, we're shocked how many young blokes particularly have got no idea just the difference between getting a melanoma diagnosed, 6 months out as opposed to, when it goes to level 3 and 4. So we do a lot of work in terms of prevention. Support and information. We have dermatologists, we have oncologists coming to our support groups to talk to our patients and their carers, to provide updated information like you've been hearing tonight. And as I said earlier, we also provide a very good service to carers, because I can tell you after 20 years, from my wife's perspective, to provide an opportunity for them to express how they're feeling and how they can contribute in a practical sense is very, very important. Melanoma WA has an excellent relationship with the Melanoma Cancer and Palliative Care Network. We work very closely with WAMAS, and Julie has been to so many of our support groups. There's a great connection there. We work very closely with the Cancer Council in WA. And as I said earlier, we also have a range of specialists that will come to our support groups and talk to your patients. But I suppose the message I wanted to give you today on behalf of Melanoma WA is to give you an absolute assurance that we as an organisation would really like to be, as the doctors looking after your patients with melanoma, we would really like to be your partners. We're a registered charity, so it costs people nothing. And you can have absolute confidence that if you say to your patients, look, as an option, as a doctor, I can look at all these things for you, but if you're seeking more, rather than go home and jump on the internet, maybe you would like to go and talk to these people, and there's copies of these outside, and I give you my assurance we will look after your patients extremely well, and they will be given good information. They will be given the opportunity to exchange information and build relationships with other patients, whilst what we don't do is start the business of telling people, what they should and shouldn't be doing. That's really in your area. So, Mark, I think in the 5 minutes I was allocated, I hope that's been of some help. The only reason Clint's not here tonight, he's down in Busselton running a cancer support group. But I can just say to you that as a patient who has lived for 20 years with metastatic melanoma, and don't worry, sometimes I wake up and ask, why is it so? After 20 years that I'm still going along well, and God willing, I don't think I've ever felt so much alive and well in all my life. But I just wanted to, say to you, as someone who's lived with melanoma for over 20 years, just how important it is to have that partnership arrangement. And Christobel, you even touched on that, whereby you have the range of services available to you to help you through that entire process. If we can be of assistance to anybody from the medical sector, as I said, our cards are out in the back. If you forget all that, you can always give Julie a call, or as I said, just remember Ross Taylor Cancer or Melanoma WA, and you will find us. Thank you very much for listening to me. I appreciate it. Thank you. Thanks very much.
Thanks, Ross. It's very inspirational to see this organisation doing such good work without any remuneration for it. Before I open the floor to questions, I'd just like to spend a minute or two to tie up everything tonight. Christobel's done an excellent job of summarising the benefits of an MDT. Some GPs I've spoken to wonder, why we provide the service and what's in it for us. I can assure you none of the clinicians in the WA Melanoma Advisory Service are remunerated for their time. It's all given up voluntarily on a Monday night, come rain, hail or storm. We do it purely out of a concern for patients, for your patients, and we're there for advice and support for appropriate referrals, or even, as I said, for any referrals where you want that advice 24/7 almost. I say that because you can leave a message and we'll get back to you the next day. So when you have a patient with a melanoma, I think the one thing that I'd really like to send to you all tonight is that this is a very exciting time in the treatment of melanoma where you and the forefront of the management can influence the outcomes of your patients. What do? We've had Tom tell us about the trials that are available. We've had Mark tell us about the benefits of patients potentially entering those trials. And so what I would implore you to do is to not overmanage your patients. One of the problems that we have in WAMAS is patients are referred to us after the GPs have done an excision and a wider excision, and often discounted or excluded their patients from potential beneficial treatments. So if you have a patient with a suspicious lesion, and you're able to excise that lesion with a 2mm margin, we're more than happy for you to do that, and we wouldn't stop anyone from doing that. If you feel that you can't excise the lesion completely with a 2mm margin, you would be better off not to touch it and to send it to us, or to send it to, when I say us, not WAMAS, but one of the surgeons that you deal with, to deal with that lesion appropriately, rather than take a shave or a piecemeal biopsy, as Dr. Quirk alluded to. If you have done a punch biopsy or an incisional biopsy or a shave biopsy and it has demonstrated melanoma, then of course the lesion needs to be excised completely, and I would ask you not to do that with a 1 centimetre margin until you've spoken to us, because frequently patients come back with a surprise that the biopsy demonstrated in situ disease and the definitive incision with a 5 or 10mm margin demonstrated invasive disease, and once again you've excluded them from potential beneficial treatment. There is no evidence in the literature for anything more than a 10mm margin, and so there is no need to give melanomas, regardless of their Breslow thickness, anything more than a 10mm margin without consultation with a specialist first. So once again, that I've seen a lot of patients come along with massive scars that they didn't really need because people have either been unwilling or for whatever reason not able to refer them for specialist opinions. So if you have a patient with a lesion, 2mm margin, if you can, otherwise refer on for appropriate treatment. There has been a model of care developed for the management of melanoma in Western Australia by Ernest Tan, a dermatologist, which is with the health department. As many of you may know, there's a lot of push for clinical networks and models of care that are going to be widely published. And within the model of care, there are recommendations along the lines that Christobel presented for anyone with melanomas greater than 1mm thick or metastatic melanomas to be referred to an MDT, and therefore it will become the standard of care as judged by your patients to send them on to an MDT. And I'm not speaking for business. We have more patients than we can currently cope with at times, but we are still happy to accept anyone. There are moves in WA to establish a treatment unit. I won't dwell on that because it is independent of WAMAS, but WAMAS at some point in the future may evolve into a unit that actually manages melanoma, and much along the lines of the Sydney Melanoma Unit, and that's something that you will see unfold over the next few years. But for the time being, WAMAS is the only multidisciplinary team that your patients can be sent to for the management of melanoma in Western Australia. At that, I'd like to open up the floor for questions. If anyone would like to direct anything to myself or any of the speakers that remain here tonight, then just raise your hand and I'll get you a microphone. It's late, sorry. Been up since 5. Any questions? None? Sorry? Yes. Don't be offended. I'm going to repeat the questions that are asked from the point of view of recording tonight.
Yeah, just a sort of a clinical question, really, in terms of a proportion of people with seborrheic keratosis, because you do see a few cases, they will have a little spot there that looks, quite different to the rest of it. It'll be a bit of pigmentation on it. So, I mean, how often will that really, transform into melanoma or any serious skin cancer?
So the question is, you have a lot of patients with seborrheic keratoses, some of which have pigmentation in them, and you're asking about what is the risk of malignant transformation of seborrheic keratoses, and the answer is 0. Seborrheic keratoses have no malignant potential. They're not even a significant marker of DNA damage or any other skin cancers. Am I right, Chris? Is there any evidence that links? So there is no evidence at all. People that have seborrheic keratoses have them for reasons other than UV exposure, and really there's no link between seborrheic keratoses and melanoma. Any other questions?
Thanks. Yeah, look, just do I understand correctly that WAMAS is then just more of an advisory body? We can't really refer patients for management to you. Is that correct?
Not exactly. It is the WAMAS has been set up as an advisory service, and the main reason that was set up is historical, for funding reasons, but also because there was a fear that patients would not be referred because there would be the perception that we would take over the management. This is before I joined WAMAS, which has been running for how long now, Julie? Since 2000, so we're in our 13th year. Having said that, we are an advisory service. All of the clinicians in WAMAS will take over the management of a patient, including their surgery, their chemotherapy, or their sentinel node biopsy, or whatever is appropriate, if asked to by the referring doctor. So if you send us a patient saying, please take over the management, or please manage, or please see and treat this patient, then we will take over the management of that patient without permission from the GP. Otherwise, we will send the patient back to the GP or whoever's referred them, specialist GP, whoever, and give them advice on how that melanoma should be managed and leave it up to them to arrange that management. But if we are asked to take over the treatment, then one of the clinicians, usually it's the clinician that sees that patient in the small group of 4, will take over the management of that patient if asked to, but not if not asked to. I have had one or two referrals, I think they've both been from the same GP, I don't know if he's here tonight, who got quite angry because we did actually take over the management because the patient needed surgery we thought by a specialist, and that was done accidentally as such. But normally we do not take over treatment, surgical treatment of the patient unless specifically asked to. Yeah. Sorry, go ahead.
If you refer a patient, I always refer my patients us to a specialist who specialises with consider that.
The question is, this gentleman here said he asked if he refers his patients with a melanoma greater than 1 millimetre thick, would that be adequate management? And clearly the answer to that is yes. I mean, at the moment, the model of care has not been published. It has not been disseminated. It's not on the Department of Health's website. And therefore, to refer on a patient with a melanoma greater than 1 millimetre, I believe is appropriate treatment to a specialist. I know that there are a lot of GPs who do subspecialise, as you like, if you like, in the management of skin cancers, and who feel competent enough to perform surgical treatment. But I don't think any of them are doing sentinel node biopsy. I don't think any of them would know the indications for sentinel node biopsy. And by not referring those patients, I think they're excluding them for the consideration of sentinel node biopsy. Now, you can argue, is sentinel node biopsy therapeutic or not? And as Mark's pointed out, there is no evidence that sentinel node biopsy or completion lymphadenectomy or therapy or prophylactic lymphadenectomy is therapeutic. There's no evidence for that. However, there is certainly evidence that sentinel node biopsy offers good prognostic information and will allow your patients to enter trials where we know the medications are making a difference for stage 4 disease, and the next step is to show whether or not they make a difference for stage 3 disease. And if you've already managed those patients, you're then excluding them from those trials. Yeah.
This is for Tom Van Hagen and perhaps Mark Lee. Is there any study evidence or do we know the number of people who are sentinel lymph node biopsy positive but who have a PET CAT that's negative, meaning those people that are sentinel lymph node biopsy positive, what percentage would be PET CAT positive? And the other question being, for those people that are sentinel lymph node biopsy negative, if they had a PET CAT, what percentage would actually have distant metastases in the setting of a sentinel lymph node that's negative?
I can answer a lot of this question. Firstly, PET CAT there's no indication for a PET CT scan in any patients with stage 1 or 2 disease. There's no evidence in the literature.
No, it's not. It's not whether there's evidence. It was to determine.
I'll get to that in a second.
Sentinel lymph node biopsy positive patients, what percentage would be missed by a PET CAT?
The vast majority is the answer. Virtually all of them. So PET CT...
has there actually been a study?
I'll get to it. PET CT scan has been widely looked at for diagnosis of stage 3, stage 4 disease, and there's never been any study that's demonstrated screening PET CT scans have any role in the management of melanoma, regardless of thickness. So even T4B lesions do not get picked up adequately on PET CT in terms of from screening for stage 3 or stage 4 in those patients. So there's no study in the literature that demonstrates any benefit in screening PET CTs. Having said that, for melanomas greater than 4 millimetres thick, in Western Australia, our practice is to offer them a screening PET CT only in those patients. And the reason for that is that the studies that have been done in those patients with thick melanomas haven't been considered to be adequate enough in terms of their numbers. And so if you look at all of the studies that look at PET CT as a screening modality for melanoma, there's no evidence to support it. We offer PET CT for patients with melanomas greater than 4 millimetres thick. Sentinel node biopsy is offered to patients with melanomas greater than 1 millimetre thick. That would mean that melanomas between 1 and 4 millimetres thick don't have anything open to them because, as I've just said, there's no evidence for screening PET CT for those patients. To get to your question, what was the other part of the question, sorry?
Sentinel lymph node biopsy negative patients, what percentage would have a positive PET CAT? Because obviously, apart from lymphatics, we've got our veins.
So sentinel node
and
biopsy,
our arteries that are taking these metastatic cells.
So sentinel node biopsy is only really used for patients with stage 1 and stage 2 disease. We only offer sentinel node biopsy for patients. So in terms of whether they have PET CTs or not, it's impossible to know because we don't use...
So I'm more asking, is there a study that's been done?
For sentinel node negative patients?
Yeah, and then they've also had a PET CAT.
As I said to you, for sentinel node, for stage 1 and stage 2 disease have been in fact for all thickness of melanomas, even very thick melanomas, the radiologists have pointed out that there is no study anywhere in the world that demonstrates screening those patients picks up lesions, and the sensitivity of a PET-CT is about 0.75 centimetres. So a lesion has to be 0.75 centimetres big to be picked up by a PET-CT. There have been studies that have compared the sensitivity of sentinel node biopsy to PET-CT, and sentinel node biopsy is far greater. Far greater.
The point of the second question was more to determine what number of people actually have metastases other than at the draining lymph node.
So we know that melanomas can spread hematogenously and lymphatically. That's a known. And all at the sentinel node biopsy, we know that people who have a positive sentinel node, and Mark pointed this out, are less likely to be alive than patients who have a negative sentinel node. We also know that those...
As you would expect.
We also know that those patients do not die from their lymphatic metastases. Okay, they die from their hematogenous metastases. So sentinel node positivity is purely a marker of the propensity of the melanoma to metastasise. But we do know that stage 3A patients have a 69% 5-year survival, 10-year survival, and those patients are dying from hematogenous metastases. So clearly, the sentinel node status is independent of whether or not the patients have hematogenous disease, but it is a marker of those more likely to develop it. Does that answer your question or not?
I think it's embodied quite a lot, and I've opened up a few ideas.
Okay. Any other questions?
Oh, Ashley.
Did you want to add anything to that, Mark?
No, but only that there was a study that did a PET scan on every patient, and then they subsequently went on to have a sentinel node biopsy, and the pickup rate of the PET scan was significantly lower.
That's the study I was alluding to. So those are PET scan negative patients who are sentinel node positive.
They all went on to the sentinel lymph node biopsy.
Correct.
And I can't remember the exact figures, but the PET scan picked up very, very few micrometastases. So
PET scan will only pick up something with a significant tumour mass. Oh, that's well known, and we acknowledge that, and that's. Oh, we've already that's what Mark mentioned in his paper, and that's well known.
I think that argument is now irrelevant.
Sorry, what's driving what? Sorry.
The question is what's driving us then to do it, and that's with the oncology.
Yeah, I think. There's been a lot of debate about sentinel node biopsy because there have been those, and there still are those who argue that we might be doing a disservice to our patients by doing sentinel node biopsies, and some people have suggested that we may increase the incidence of in-transit metastases by clearing the draining lymph nodes. All of those are arguments that have been levelled, and this has been debated ad nauseum, and we are well aware that at this stage there's no proven therapeutic benefit for sentinel node biopsy or completion lymphadenectomy, as I opened my statement with. However, we do know that regardless of all other factors, sentinel node positive patients have a poorer prognosis than sentinel node negative patients, and that's what we're trying to address with these studies that Tom's talked about. Yeah.
Is there any role of doing chest X-ray?
None at all.
Not at all.
There's no evidence to support any screening investigations for melanoma patients stage 1 and stage 2 disease. So no chest X-rays, no blood tests, PET scans, nothing else. Now people still feel that they should do liver function tests and X-rays and whatever, and I don't really have an issue with it, but there's no evidence to support it. Yeah.
About sentinel node biopsy and about the staging of which
No, it's not. An excisional biopsy should only be done with a 2 millimetre margin.
Yes, but if the melanoma is bigger than that, you're going to have a bigger lesion than 1 centimetre.
It doesn't matter. The margins away from the melanoma have to be.
Less than, I get it.
Okay. No. And the reason for that is, as Mark pointed out, every single spot on our body drains to a specific lymph node. And we believe that the diameter of that area which will drain to that lymph node is probably about 2 to 3 centimetres. Therefore, if you get more than 2 to 3 centimetres away from the melanoma, you're going to potentially go to another sentinel node that belongs to another area.
So you want the sentinel node biopsy done between the initial excision
and the wider excision. The wider excision should be at the time of the sentinel node biopsy, correct. That's a good question, thank you. Any other questions?
What exactly is the mechanism of regression? Why does it give a poor prognosis? If you see it from in situ, does that bump it up to 1 centimetre margin?
I would love to answer that question. I'll ask Ben to do it though.
So the mechanism of regression is like an extremely long talk, but we believe it's probably largely T-cell mediated, so it's an immune response against the melanocytes. The most striking example of that is in what's called tumoral melanosis, in which the melanoma is entirely removed and you're just left with melanophages which have chewed up melanin, and those patients almost invariably die of metastatic melanoma in relatively short sort of period of time. The evidence for partial regression is less clear. A lot of people believe that it probably leads to things like understaging of the melanoma, but that's a little bit difficult to sort of understand in a number of ways. The point about regression in thin melanomas is that if you look at people with Clark level 2 melanomas, they have a very low rate of developing metastatic disease overall. But when you do see patients with metastatic disease, and actually the study that looked at this was from Western Australia, which was a good study, when they do develop metastatic disease, it's in patients who have level 2 melanomas but with regression. And so we sort of infer from that there was more volume of tumour in the dermis at some point in the past. It may also be that the process of spreading actually induces the immunologic response that causes regression. As to the question, if someone has an in situ melanoma and there's changes of regression in the dermis, one can infer from that there was some melanoma in the dermis. Regression is a dermal process. What's probably more common is misinterpretation of melanophages and other changes in the dermis that occur under a melanoma in situ as regression, and that's a very difficult distinction. So the short answer is if someone doesn't have identifiable invasive melanoma, then they should be considered to have in situ melanoma.
Thanks, Benjamin. Yeah.
Just one quick question. I asked this with Tom Van Hagen's talk. Do people have to have a sentinel lymph node biopsy to actually get onto trials?
No, they just have to have positive lymph nodes, then they need stage 3 disease. So you're more likely to pick up stage 3 disease, obviously, if you're doing more lymph node biopsy.
So at this stage, there's no trials for stage 1 or stage 2 disease in melanoma, but stage 3 disease is the current trials that Tom was talking to, and stage 3A, which is a positive sentinel lymph node, is an inclusion. Yeah.
Are these tests for BRAF done on those nodes themselves that are positive on the tissue of time, or can it be obtained from the previously excised lesion that's done?
Can be obtained any of the lesion, any of the melanoma. There are studies that have demonstrated that for melanomas that develop metastases, that the BRAF status of the metastases is the same as the BRAF status of the primary, so it doesn't matter.
So that formula doesn't destroy that specific.
No.
No, it's a PCR specific.
Any other questions? Once again, thank you all for coming tonight. I think it's been a really comprehensive summary of where we are at melanoma. Thank you.